My story about advocacy, community, and personal accountability begins with the story of Hilda. This is a patient who became a very dear friend and completely changed the trajectory of my career. Hilda left Mexico when she was a child, escaping poverty and domestic violence. I met her when she was in her 20s. She had 2 small boys, and she had just been diagnosed with kidney failure. Because she was undocumented, she only had access to dialysis once a week, basically every 7 days when she was on the brink of death. She'd come to the hospital short of breath, nauseous, hyperkalemic, and what she most worried about were her boys. Her boys stayed in the hospital with her, they weren't going to school, and part of this was because they had weekly death anxiety. They didn't know if their mom would survive to the following week. In 2013, Hilda had a cardiac arrest at home. Her boys called an ambulance, they witnessed her receive CPR, and it was after that that she made a very difficult decision. She decided to find adoptive parents for her boys, and she stopped emergency dialysis, and she died on Mother's Day in 2014. After Hilda passed away, it was very hard. Before she passed away, I actually connected with several large and small dialysis organizations, as well as legislators in the governor's office. And I couldn't convince anyone to dialyze her, and I didn't understand the policies to change them. I knew that I couldn't continue to provide this type of care, and I felt compelled to lean in and change this. I read everything possible on this and came across one article written by a health executive who worked for CMS, and in it he described how one of the necessary next steps was to conduct research to demonstrate why this needs to change. And at the time, I'd been a full-time clinician for about 6 years, had 0 research experience, and intentionally worked at the safety net hospital because research was not required. But I decided in that moment to start applying for grants and essentially to learn to conduct research for the sole purpose of changing policy. And so as I describe our team's successful policy change, I am going to describe 6 strategies that were key in changing this in our state. The first was connecting with our patients and caregivers. They became my partners in all of this work, in the research, the advocacy. They created a WhatsApp group where we all communicated with media, with some of our decision makers. They also created a nonprofit group called Club de Niños Latinos, where they organized themselves and started connecting with people across the country in other states. And as our research grew and our community work grew, we grew our coalition and started including decision makers and other people. So this group of incredible people was honestly the force that pushed this work forward. The next key strategy was conducting advocacy-informed research. We connected with lots of allies and people who disagreed to inform some of our most important and moving research questions. The first publications were qualitative. The very first one was qualitative interviews with undocumented immigrants receiving emergency dialysis. And they basically described significant physical and psychosocial distress from having to wait for their symptoms to accumulate every 7 days. They also described weekly death anxiety and risking death to meet eligibility criteria, because many of them would consume foods very high in potassium just outside the hospital door so that their potassium would be high enough, knowing that it could push them into cardiac arrest. We also interviewed caregivers and then another study interviewing clinicians. Clinicians described several drivers of burnout, including needless suffering and high mortality. And this was especially true in our ED providers, who saw patients coming in unable to speak in full sentences because they were full of pulmonary edema. And then by the time they were dialyzed, they were discharged and able to participate in life. We also published several quantitative studies, one demonstrating worse mortality, another one worse quality of life, and then worse symptom burden. And I just want to mention that compared to the quantitative studies, the qualitative studies actually drew in more attention from media and policy stakeholders because they were the patient narratives that people could truly understand. The next key strategy was developing effective communication. And we were very intentional about engaging with people who disagreed with us so that we could understand their values and perspectives and really use that to frame a lot of our messaging. We worked really hard to build relationships with media in the state and trusting relationships. We need them as an ally, especially in public advocacy. And what we did for them is we gathered stories. Patients were willing to be interviewed at the risk of deportation. We wrote press releases. We basically created a roadmap for how they could cover this. And it increased our reach far beyond Colorado, which was truly incredible because then we started conducting multi-site studies and other things. The fourth key strategy was understanding policy and the process to change this. This was critically important so that we could be very strategic about the relationships that we needed to build and influence decision makers. Many of you are familiar with EMTALA, or the Emergency Medical Treatment and Active Labor Act. That's the language you see on this slide. But basically, hospitals are required to screen, stabilize, and treat patients found to have an emergency. And many states abide by this exact language. But what is critically important and what we learned from our policy analysis is that CMS defers to states to define the qualifying conditions and services. This means that a state could include kidney failure and provide dialysis and other services. And so CMS, again, defers to states, and this is how many states had modified their policy for this patient population. And so in conducting advocacy-informed research, disseminating this information through effective communication, and being very strategic about the policy change, we connected with several decision makers. Patients came with us, and on February 1st, 2019, Colorado expanded benefits for undocumented immigrants, including standard dialysis, and then a few months later, also peritoneal dialysis. And this is one of my favorite pictures because this shows the solidarity amongst patients. They have their hand that has their AV fistula in the middle. So just, incredible partnership with the patients. The fifth and critically important strategy was to conduct research post-implementation of the policy because it's critically important to document the outcomes as well as to do cost analyses. And so on the right, you see a study. It's a pre-post intervention study. I looked at quality of life, symptom burden, and also conducted interviews before patients transitioned from emergency and then after they transitioned to standard dialysis. And patients experienced, of course, an improvement in quality of life, a reduction in symptom burden, and also felt humanized and were able to start working again. And on the other side, it's an economic analysis using our state Medicaid data. Prior to the policy change, the cost was $20,000 per person per month, and it was reduced to $5,500 per person per month. In this slide, I show the dissemination of the work. One publication was co-authored with our state Medicaid director, which was incredible because then she and I both went on to mentor other states to make a similar policy change. In the middle, I collaborated with the National Kidney Foundation and ASN to write a letter addressing state Medicaid directors, urging them to do the same, and several professional societies signed on, including SGIM and SHM and many others. And lastly is an ASN website. They actually created a committee that meets twice a month sometimes, but essentially they sort of put everything on one website because they realized that it was kind of a burden to connect with physicians across the country each time someone was interested, and so they put everything in this one website, and they have a team that provides support. So in 2019, there were about 15 states that provided statewide dialysis. We looked at this again in 22, and there are now over 20 states, and we're actively working with several more states right now, despite the current administration. Since this initial work, our team has led several policy changes, some sub-regulatory, bill development. We have worked as a team with our patients and caregivers and many in the state on many policy changes, and also conducted research. So the team of patients that I showed you initially, they've actually been part of my community steering committee for the past entire decade and have informed many of our clinical trials. And in this moment, we're seeing our policies rescinded, paused, budget removed. My grants have been canceled. But I just want to share that I am choosing to fight. I'm working with the state very closely. I'm very involved on boards. I'm helping them with strategy. How do we, despite these changes, continue to provide care for this patient population and do so in a way that keeps them safe?